Again, I would like to thank the organizing committee for inviting me and the chairperson. Thank you for the audience again. I'm supposed to speak about neurohormonal blockade, and is there still room to go? And I would like to thank Dr. Maryam for excellent summarization of what I'm speaking as well about. We all know that heart failure treatment goals focus on prognosis, morbidity, and prevention, and with the objectives, the main objective is with regard to prognosis, of course, to reduce the mortality of our patients, and again also to get some benefit with regard to morbidity by relieving symptoms and signs and improving quality of life, and of course prevention is the most important signal that we are still unable to achieve what we expect. And when we come with the pathophysiology of the HFrEF, after damage of the cardiac myocytes and the extracellular matrix leads to changes in the size and the shape and the function of the heart and the cardiac wall stress, and it ends up with the systemic neurohormonal overactivation, which ends up with the morbidity and the mortality in relation with the arrhythmias, pump failure, and the heart failure symptoms regarded with the dyspnea, edema, and the fatigue. And we all know the story of the, in relation with the myocyte loss, which ends up with the problems in the energy supply and the demand ratio, problems with the afterload and the preload, and we end up with the change in the, we end up with the remodeling, and which is related with the neurohormonal activation, which is based upon the natriuretic peptides, prostaglandins, bradykinin pathway, of course, renin-angiotensin, aldosterone pathway, RAS pathway, namely sympathetic nervous system, endothelin pathway, and the arginine vasopressin pathway. And with the cooperation of all of these factors, we end up with either weakened heart muscle or stiff heart muscle, which are both equally important. And we all know that heart failure therapy has evolved over time. For example, by 1980s, we only had digoxin and the nitrates in our hands, but by 90s, we had ACE inhibitors in our hands. And just by after the 1995, the previously contraindicated treatment options was class 1A indicated by the well-established clinical trials. And we have still improving, and all of them are related with kind of, all of the achievements are somehow related with the neurohormonal system, neurohormonal antagonism. And we all know that systolic dysfunction leads to activation of at least 3 major neurohormonal systems. These are sympathetic nervous system, which are based on epinephrine and the norepinephrine on the alpha and the beta receptors, and ends up with the vasoconstriction. And it's related with the RAS, increased RAS activity, vasopressin activity, heart rate, and the contractility. And on the other hand, the second effector is the renin-angiotensin aldosterone systems, which is based on mainly on the angiotensin 2 and the angiotensin 1 receptor ends up with the vasoconstriction. And on the counter, on the opposing system, we have natriuretic peptide systems, which is against, of course, vasoconstriction, and it decreases blood pressure, sympathetic tone, improves natriuresis, diuresis, and it's against the actions of the RAS and the sympathetic nervous system. And this is a very old slide coming from an old textbook. We all know that angiotensin 2 has downstream effectors. It increases arginine vasopressin. It ends up with a vasoconstriction. It ends up with severe renal effects associated with the sodium retention, and also have central nervous system effects. So angiotensin 2 plays a central role in the pathophysiology of heart failure-related things. And the overactivation of the RAS and the central nervous system underpins the heart failure therapy. And the overactivation of the sympathetic nervous system, we all know that, just blocked by the action of the beta blockers. So we are able to block this activation, overactivation of the central nervous system, sympathetic nervous system in the heart failure pathophysiology. And on the other hand, just by the RAS inhibitors, namely ACE inhibitors, ARBs, or MRAs, we are able to block the actions of the RAS system, and we are able to revert back the actions of the angiotensin 2 through the action of angiotensin 1 receptor. But on the other hand, natriuretic peptide system usually left alone with some exceptions of administering them externally. And we all know that the clinical trials of heart failure with reduced ejection fraction, I am here really focusing on the heart failure with reduced ejection fraction. I am not touching upon the heart failure with preserved ejection fraction, because I still believe that there's nothing. We still have some more to do on HFpEF. But in the clinical trials of HFrEF, we usually, the successful trials, most of the successful trials relies on, heavily based on the blocking of the overactivation of the renin-angiotensin aldosterone system and the sympathetic nervous system activation. And the only exception until now was the publication of the SHIFT trial. You all know that. And recently we had the paradigm HF trial, which shifted our paradigm into overlooking from the blocking the system of sympathetic nervous system and the RAS system to the activation of the, or just blocking the catabolism of the natriuretic peptide system. And we all know that chronic HFrEF survival rates have improved over time with the introduction of new therapies. We all know, but there still remains a significant mortality. And with the ACE inhibitors, we all know that we end up with some around 15 to 16% mortality reduction, although we have quite a good amount of absolute risk reduction, about 4.5%. I'm just skipping the ARBs because ARBs are alternatives to ACE inhibitors. With the beta blockers, we have more than 30%. With the MRAs, around 30% mortality reduction, and with about considerable amounts of absolute risk reductions in these therapies. But you see the ACE inhibitors remained a little bit at the back of, with regard to other therapies of the mortality reduction. And one important point is that beta blockers and the MRAs were always added on top of the existing backbone ACE inhibitor therapy. What about natriuretic peptides? We all know that natriuretic peptides are quite important. Release of ANP and the BNP from heart and the CNP and the vasculature ends up with the decreased sympathetic outflow, decreased vasopressin, decreased salt appetite in the water intake, increased sodium loss, decreased aldosterone, decreased renin system, decreased hypertrophy and the fibroblast proliferation. So we end up with the beneficial vasodilatory actions through the ANP and the BNP system. On the other hand, CNP has some kind of a different mode of action. We still have some lack of knowledge with regard to actions of the CNP, but CNP is also influential in the endothelial level. So then how can I increase the NP levels in the body? We all know just simply by administering it. We know from the VMAC trial, SHFG trial, it's a synthetic BNP analog. It is valid for only for BNP. So just simply by administering the BNP, we can increase the NP levels in the body, but increasing NP levels in the body didn't work, just as good as we expect, just because we know just increasing the BNP does not equal to efficient BNP in the circulation, because efficient BNP, BNP is a protein molecule. It relies on the existing molecule protected from the cleavage from endoproteases circulating in the body. So just the second way could be just by decreasing their catabolism. It's a common pathway. And one enzyme, it's neprilysin neutral endopeptidase. It is NEP. It degrades many endogenous vasoactive peptides, including natriuretic peptides, adrenomedullin, bradykinin, substance B, calcitonin, gene-related peptides. So it's the neprilysin action to deactivate and produce the inactive metabolites of these endogenous vasoactive peptides, which are actually beneficial with regard to vasodilation and the some beneficial actions of expected beneficial actions of heart failure management. So neprilysin inhibition, excuse me. So if I block the neprilysin, if I inhibit the neprilysin, I end up with the decreased neurohormonal activation, decreased vascular tone, decreased fibrosis and the hypertrophy, and a decreased sodium retention, all of which are quite beneficial. But the amount of neprilysin inhibition can determine the amount of the vasodilatation and the amount of the levels of endogenous vasoactive peptides, including bradykinin. So if I increase the amount of endogenous vasoactive peptides too much, I may end up with some side effects, and we all know from the unexpected side effects of angioedema from the Overture trial, which was stopped because of the increased risk of angioedema. But we should keep in mind that neprilysin inhibition has to be accompanied by simultaneous RAS blockade, just because of neprilysin is an enzyme responsible for degradation of angiotensin 1 and angiotensin 2, turning the angiotensin 2 into inactive fragments. So if I block the system, inhibit NAP, I may end up with the increased amount of vasoactive substances, but also increased amount of angiotensin 2 in the circulatory system, which means actually neutral effect on the circulatory system. So I am in need of blockade of the angiotensin 2 actions, and which could be achieved by just simply by using ARBs cleverly. Neprilysin is an enzyme with a high affinity, both ANP and CNP, and interestingly low affinity for BNP. And by the actions of ANP and the CNP, we end up with vasodilatation, improved diuresis, natriuresis, and also increased venous capacitance. And BNP is somehow more resistant to hydrolysis by neprilysin than ANP and the CNP. But we all know that BNP also decreases when neprilysin and the RAS are simultaneously inhibited. So we all know that, we heard about that LCZ696. It's a clever combination of angiotensin receptor blocker with the neprilysin inhibitor sacubitril, and it's also called ARNI. It's a salt complex. You know, it's 1-to-1 molar ratio. It's found sacubitril and the valsartan, a clever enough combination, and it's tested in the PARADIGM-HF trial. Is the study to test the effect of LCZ696 on morbidity and the mortality in patients with HFrEF. You all heard about the Paragon trial, where the HFpEF is on its way still, and we are part of the HFpEF Paragon trial as well. And the PARADIGM-HF was designed to determine the place of ARNI as an alternative to ACE inhibitor therapy. We should keep in mind that all the remaining trials were added on top of the existing therapy, but this trial was tested to take one important backbone of therapy out and to put something else into the backbone of therapy. And we all know the study outcomes. It's about the 20% reduction in the primary endpoint, but more importantly, it was associated with a 20% decrease in the CV mortality, and also 21% decrease in the first hospitalization for heart failure, but more importantly, 16% reduction in the total mortality. So overall, quite impressive results. We ended up with the PARADIGM-HF trial. And we, as I told you before, drugs that reduce the mortality in heart failure with reduced ejection fraction, when we look at the amount of reduction in mortality, we see that with the ARBs and the ACE inhibitors are staying behind of the beta those achieved with the beta blockers and the mineralocorticoid receptor antagonists. And this could investigate it in a putative manner, in an imputational manner, but by the John McMurray and the co-workers. Because, you know, in the LCZ696, we were able to compare the enalapril versus LCZ696, and we knew that enalapril was compared with the placebo in the SOLT trial. We should keep in mind that it will never become possible to compare LCZ696 to placebo, because it is, you know, it's going to be unethical. But it can only be do an imputational, in a putative manner. We can compare it. We can make a kind of a statistical analysis, and they did it because they have all the data together with them. And if we had compared the LCZ696 to placebo, we ended up with the results of with regard to CV, that we ended up with more than 30% reductions in the CV mortality, and it became quite like those achieved with the beta blockers and the MRAs. So just, it is kind of, we should keep in mind that the blockade of the RAS system together with the NP system ended up with the benefits achieved similar rates to the beta blockers and the MRAs. So this is the putative analysis. What about safety? Yeah, safety is a concern, of course, with the LCZ696. We ended up with more hypotensive episodes in patients with LCZ696, despite run-in period, we should keep in mind. What about neurohormonal activation? Are there still remains? We have achieved a lot of things with the blockade of the renin-angiotensin-aldosterone system, along with the blockade of the angiotensin II and the aldosterone system, and also sympathetic nervous system blockade of the actions of the norepinephrine. We ended up with some kind of neutral results by the blocking of the vasopressin system, you know, from the Everest trial, which was kind of a misconducted trial, we should keep in mind. On the other hand, with regard to blockade of the endothelin system, we ended up with neutral to negative results, because blockade of the endothelin system ended up with severe hypotensive episodes. And we are still at the back of the blockade of the cytokine systems. And there are also upstream pathways, including microRNA pathways, and also aliskiran pathway. Aliskiran, you know, just it's a direct renin inhibitor. So we can block the renin-angiotensin-aldosterone axis upstream. And now it's being tested. You heard about that in the Atmosphere trial. I am principal investigator of the Atmosphere trial, and I can say that the results will be announced in the 2016. Next year it's going to be, we will see the results of the Atmosphere trial as well. So as an overview, just beta therapy is used in heart failure. We have drugs in our hands with a proven efficacy in reducing mortality by inhibition of the angiotensin II production or blocking of the AT1 receptors, namely ACE inhibitors or ARBs, by the competitive antagonist of beta adrenergic receptors, blocking of the sympathetic nervous system to reduce, or by reducing the release of renin, of course. Beta blockers are able to reduce the release of renin, but by beta blockers, namely bisoprolol, carvedilol, metoprolol, metoprolol succinate, of course, and the nebivolol, we are able to block the system, and we ended up with a proven efficacy in reducing mortality. Again, with the competitive antagonist of aldosterone receptor by the mineralocorticoid receptor antagonist, spironolactone and the eplerenone, we reduce the mortality of these patients. And on the other hand, we have drugs to improve the symptoms of our patients just by using thiazide loop diuretics. And the competitive antagonists of vasopressin receptors, we all know that vasopressin pathway is an integral and important pathway, important neurohormonal pathway in patients with HFrEF, but still we couldn't achieve the reduced mortality in these patients. And we have NO releasers with the organic nitrates. We can improve the symptoms. We have cardiac glycosides. We have beta antagonists, and we have phosphodiesterase inhibitors, which can help us to improve the symptoms. But there still remains a lot of things to do. And on the other hand, I completely agree. Just I didn't like my slide. I like the slide of Dr. Maryam more than me, because I put Arnie completely covering the actions of the ACE or ARBs, but I disagree with this slide. I agree with the slide of the Dr. Maryam, just because there are still more data with regard to Arnie in replacement of ACE inhibitors or ARBs, just because we do not know what will happen in the post-MI patients, first of all. Secondly, we do not know what is going to happen in patients with HFpEF. It's going to be a landmark result if we end up with the positive results of the Paragon trial. And also, we do not know what will happen in patients with the acutely decompensated heart failure, in whom the neurohormonal axis is significantly and acutely deteriorated. And in these cases, we need more data in replacement of ARNI, in replacing ACE inhibitors or ARBs. And as far as I know, the transition study, which will evaluate the utilization of LCZ696 in acute heart failure patients, is on its way. But I heard that Novartis is not going to support the post-MI study. Unfortunately, it's a sad story. But I could say that in the next guidelines, I think it is going to be class 1B indications, kind of a narrow, not overall indications, covering all of the things done by the blockade of the renin-angiotensin aldosterone systems. Thank you very much for your attention.